Okay, good morning. Today's class will continue with the CNS. This is a practical class, actually, a CSF analysis. So in the first class, I had shown you how the CSF is produced. So this picture, if you see the purple area space, that is the CSF. And the CSF is produced by the choroid plexus here. You can see the arrows, and the whole brain and the spinal cord is bathed in the CSF, providing a cushioning effect. So these are the arachnoid villi. These play an important role in the absorption of the CSF. So 70% of the CSF is produced by the choroid plexus in the lateral, the third and the fourth ventricle, and the remainder is also produced by the surface of the brain and the spinal cord. The total volume is 90 to 150 ml, and in certain situations we have to collect the CSF for analysis, and for that we need to use a lumbar puncture needle under aseptic conditions. And the lumbar puncture needle, I'll show you a picture. In children it has to be a bit shorter. So these are pictures to show you how a lumbar puncture is being done. I couldn't get a good video, so I've just accumulated some pictures. So as you can see here, just as we do a biopsy or anything to do with aspiration in the abdomen, we have to do a thorough cleaning. So this is the way. First you clean that, you identify the area. We'll talk about the sites later on. First we identify the area, clean it with spirit, and then clean it with tincture iodine, and it has to always be from the center towards the periphery while cleaning, and again clean with spirit that particular area. And the positioning is extremely important. If it's a baby or a child, you can always position them this way. This is a curled up position. In the knees will be brought up to the chest if possible, and in a child the nurse can hold the child to, and this is the purpose for this, is to expand the space through which you can do the lumbar puncture. So this is how the needle is inserted, and I'll show you a picture through what I will explain to you how the needle goes through what structures it will go through, and then we collect the CSF. This is a picture of a lumbar puncture needle. You can see here that it is extremely thin. The needle is extremely thin, and inside the needle there's a stillet which is looking like the needle only. And I hope you remember bone marrow needles. Whenever we take a viva and we ask you to identify needles, some people have picked up a bone marrow needle and identified that as a lumbar puncture needle, which is wrong. Bone marrow needles are extremely hard. They have to penetrate the bone, so they are very, very hard. But lumbar puncture needle need not go through the bone. So you will see that extremely long, fine, and very flexible and pliable needles. Okay, but both of them will have a stillet. The main idea behind the stillet is that when you are puncturing through the skin, you don't want bits of the skin to block the needle. And if you do not put the stillet, the bits of skin and other tissue will block the needle, and when you reach the CSF space, the CSF cannot travel through the needle to come into your tube. So that is the purpose of the stillet. And just like we do in bone marrow needle. Bone marrow needle also has a stillet through which you go through the skin, the fat, the muscle, the periosteum, the bone, and then you reach the marrow. Then only you let the stillet out. The same way in lumbar puncture, you go through the various, like you can see here, you have to go through the skin, the fat, there's an underlying muscle here, and then you get into the space. Okay, so for this purpose you have to put a stillet. This is not what we use in NEIGHRIMS. This is available in other places, but what we use in NEIGHRIMS is this one. This is the spinal needle, which is extremely fine and extremely pliable. And like I said, do not mistake this for a bone marrow needle, and do not mistake the bone marrow needle for a lumbar puncture needle. Bone marrow needle it has to go through the bone. So it is extremely hard. It is not at all pliable, and it's thicker and shorter. Okay? But a lumbar puncture needle is very fine and long and extremely flexible and pliable. But both will have a stillet for purposes which I have told you just now. So lumbar puncture can be done with the patient lying down in a lateral position, left lateral position, or if the patient has breathing disorders, or in young infants, you can make them do in a sitting position. In children, you may do in a sitting position. So these are the sites for lumbar puncture. In adults, the site is between L3 and L4. In children, it is between L4 and L5. And in infants, it is L5 and S1. Does anybody know why the sites differ? Can you put in the chat? Do you know why the level of lumbar puncture is different in infants and in adults? If you don't know the answer, I would like you to look up the answer yourself, okay? And you can probably give a message in the WhatsApp. So in infants, it is lower down. In adults, it is higher up. So then in when lumbar puncture is through the lumbar area, but there are other types of punctures from which you can attain CSF, okay? So somebody has put the answer here in the chat. The spinal cord ends in higher level in children, okay? In infants, actually, that tail end of the spinal cord extends lower down. So that's why you have to do the LP lower down. Otherwise, you will poke into the cord, okay? So let's see. So the other sites for acquiring CSF is a cisternal puncture, when there is a spinal cord block or when there's vertebral deformity in which you cannot really identify a space, or when there is a skin infection or ulceration at the site of doing lumbar puncture, then cisternal puncture may be done. And in infants, you know that the fontanelle is open, so that's why a ventricular puncture may be done in infants. So like I said, in infants, since the fontanelle is still open, the bones are not yet fused, so through this fontanelle, a needle may be introduced at aseptic conditions and CSF may be procured. And in adults, the most common position which is used is this. And most importantly, this position is extremely important. If you notice, they are put in the left lateral position and the head should be a little bit down to extend the neck, and the legs are pulled up, the knees are pulled up towards the chest. And the purpose for this is to expand this space as much as possible. And this is the cisternal puncture, which is usually never done. It's quite dangerous to do except if you're experienced. But this is a cisternal puncture, and I have told you the indications. Only when this is not possible, if there's a surface ulceration or there's a person with a defect in the vertebrae, then maybe you have to go for something like this. So the method of collection, the amount collected, remember when I showed you the CSF findings in the table, we had to measure the pressure of the CSF first. And usually when there is a CNS tumor, which is occupying space in the brain, so it is expected for the intracranial pressure to raise. So in that case, like I said, if the pressure is too high and you do a lumbar puncture, the CSF will come gushing out and suddenly the pressure goes low. It may cause herniation of the brain. So that is why it may be a contraindication to do a lumbar puncture in people who have space occupying lesions in the brain. So the pressure, CSF pressure, is very important for you to estimate and then decide whether you can do a lumbar puncture or not. So the amount which is usually collected is 6 to 8 ml, not more than that. And usually it is collected in 3 sterile test tubes, dividing 2 ml each for microbiological examination and culture. So remember, it has to be absolutely aseptic and in sterile because culture needs to be done. Okay? And usually what we do is the first tube we always collect for culture because we expect that to be as aseptic and sterile as possible. So the first tube will always be for microbiology, and the second tube is for biochemical and immunological studies, and the third tube will be for clinical pathology, where we calculate the total cell count in the CSF, and we also look at the differential count, and if necessary we make a smear and look at the cytology. We look at the types of cells and also if any malignant cells are there in the CSF. So one thing you should remember about CSF is that when CSF is collected, it should be immediately transported to the lab. And in the lab, we should examine it within 1 hour. If it is not possible for us to examine within 1 hour, we refrigerate and put at 4 degrees. But if it is microbiology, if it is meant for culture, then if you're suspecting a bacterial meningitis, especially Neisseria, sometimes epidemics happen, Neisseria meningitis in children, the CSF should never be refrigerated because Neisseria gets destroyed in the cold. So remember these are very, very important things for you to remember, that CSF should be examined immediately and it should not be left in the ward after you do LP. It should be sent immediately to the lab. Now, indications for lumbar puncture. The diagnostic indications is if you're suspecting meningitis and you're not sure whether the meningitis is bacterial, viral, fungal, tuberculous, or syphilitic meningitis. So you have to do a CSF analysis. If there is a subarachnoid hemorrhage, if there is primary or metastatic disease. Primary disease usually in children having acute lymphoid leukemia. In leukemia cases, CSF is done because we need to see how much the disease has spread. And another thing is also for therapeutic indications like intrathecal injection of the chemotherapeutic drugs in prophylaxis or in ALL relapse. So this is very important in ALL. So before we actually do this intrathecal injection, at that point of time, the CSF is taken out and examined and we look for lymphoblasts in the CSF. So in demyelinating diseases also, CSF can be studied, and also injecting radio-opaque dye for myelography in radiology. Therapeutic indications, most of the surgeries nowadays, if it is possible, general anesthesia is avoided and spinal anesthesia is recommended. So this is one of the therapeutic indications. And the other therapeutic indications, like I told you, is injecting chemotherapeutic drugs within the CSF space through a lumbar puncture site. In cases of ALL, either as a prophylaxis or as a relapse, in cases of ALL relapse. So this is to differentiate between the traumatic tap and a subarachnoid hemorrhage, because in both there may be some difference in the appearance of the CSF. So normally CSF is extremely clear and transparent, okay? But many a times, especially when you're not very experienced with doing lumbar puncture, your first 2 or 3 lumbar punctures may come out as traumatic taps. So traumatic means that the needle is probably gone through some capillaries and then you get RBCs in that. Okay, so the traumatic means you will see a lot of RBCs. So in a traumatic tap, your RBC count and gross appearance of bloodiness will be there. And in decreases, this word decreases basically means that if you are collecting, like I said, you collect 6 ml of CSF and we collect it in 3 sterile test tubes. So the first one goes to microbiology, then biochemistry, then pathology. So when we are collecting the first tube, 2 ml, and then we collect the second tube, then we collect the third tube, if you compare the color between these 3 tubes, you will see that the first tube appears more red, the second tube less red, the third tube almost clear. So that shows you that it's a traumatic tap. So that is what we mean by the RBC count and gross appearance of bloodiness decreases in the 3 tubes. But if it is a pathology like subarachnoid hemorrhage, the person has a subarachnoid hemorrhage, then between the 3 tubes, there'll be hardly any change in the color of the CSF. I hope you have understood that. Okay, so a traumatic tap, if you collect in 3 tubes, the first tube will be reddish, the second tube will have a tinge of red, and the third tube will be almost clear. So you know in that case that it is not that the person has a pathology, it is because of the procedure itself that there is some trauma. That is why RBCs have come, and by the time you collect the third tube, the bleeding from that capillary has stopped and the RBC count and the gross appearance of bloodiness has reduced. But in subarachnoid hemorrhage, all 3 tubes will show almost the same color. And when we examine, we will look for WBCs and RBCs microscopically. This will be similar to peripheral blood, because you will find RBCs, you will find the WBCs because it's traumatic. So basically you have poked into a capillary and the blood has come. So that if you examine under the microscope, it will be similar to peripheral blood. Whereas in subarachnoid hemorrhage, it will not be similar to peripheral blood. RBCs will be very less, and in fact WBCs will be much more. Then if you keep it standing, if it is a traumatic tap, the RBCs will settle down and the supernatant will appear clear. Whereas in subarachnoid hemorrhage, it will be xanthochromic. Xanthochromic means, well, it has a pale yellowish tinge. You know very well that RBCs, when they lies within the body, they go through pigment changes, right? The color changes. So in subarachnoid hemorrhage, if you take out the CSF and it is slightly straw colored in all the 3 tubes, you know that the bleeding is actually happening from before, and now you are getting the evidence by looking at the color of the CSF. Okay, so that is xanthochromia. Then clotting of the fluid, if there is a lot of RBCs, of course it will clot, it will behave like blood. And subarachnoid hemorrhage, it will not clot. The protein concentration will be raised in both. Then if you repeat lumbar puncture at a higher level, the CSF should be clear, provided it's not a traumatic tab again. Okay, but if you repeat a lumbar puncture at a higher level in subarachnoid hemorrhage, it will remain bloody or it will remain xanthochromic. And the opening pressure is usually normal. Here, because of the subarachnoid hemorrhage, the opening pressure, CSF pressure, will be elevated. So I hope you understood the differences between the CSF in a traumatic tab and a subarachnoid hemorrhage. This may not be asked of you in pathology itself, but it is an extremely important question for you in medicine for practical purposes. So this is what I mean. You can see this tube. This tube is extremely clear and transparent. This is how CSF should be. But in this tube, there's a tinge of yellow. This is known as xanthochromia. And this happens in subarachnoid hemorrhage. It basically means that the bleeding has already happened in the brain. And the RBCs are already showing pigmentary changes. And it has sort of leaked into the CSF. And that's why you're getting a yellowish CSF. So this is exactly how it should look. But this is a schematic diagram. So normal is clear. Xanthochromia is a tinge of yellow, and if there is traumatic tab, it will look reddish because of the fresh RBCs which come into the CSF. Now, there is always contraindications. Contraindications of CSF analysis are raised intracranial pressure if it is extremely high, because all conditions will have raised intracranial pressure, but you have to decide at which point you should or should not do the CSF analysis. If it is extremely raised, it is always a contraindication because of herniation of the brain, which might lead to the patient dying on the spot. Local infection, this is because you might introduce infection into the CSF and cause an iatrogenic meningitis if we do not take care that the skin is normal at that area. Disseminated sclerosis, brain tumor, severe scoliosis. These are brain tumor, it's basically because the ICP will be really, really raised. And severe scoliosis, you know very well that the whole anatomy of that region will be different, so it will not be like what you expect it to be for a lumbar puncture. Complications, this I've already told you, if there's a very raised intracranial pressure and it is anyway done, there can be herniation of the cerebellum through the foramen magnum due to raised intracranial pressure. There may be a hematoma, which may either be extradural or subdural, or introduction of infection by the needle through the infected skin leading to iatrogenic meningitis. So how do you examine the CSF? The first thing we look at is the physical examination. So CSF pressure should be examined by the clinician before performing the lumbar puncture. And the normal CSF pressure in infants and children is 40 to 100 mm of water. Causes of raised intracranial pressure is in meningitis, cerebral edema, space-occupying lesions of the brain. Causes of decreased intracranial pressure is in dehydration and circulatory collapses. The appearance and the color of the CSF, this by now you know that normally it's clear and watery. If it is turbid or cloudy, this is probably because of pus, and this is usually a picture seen in acute pyogenic meningitis or bacterial meningitis. But if it is extremely thick and turbid, it may be a tuberculous meningitis as well. Xanthochromia is seen in subarachnoid hemorrhage because of the tinge of yellow appearance to the CSF due to RBC lysis from 24 hours before. Microscopic examination, this is what we do in clinical pathology. We do the total leukocyte count and the differential count in CSF. This will immediately give the clinician a clue as to what could be the cause for the meningitis. So I don't think you really need to know so much about this, but if you remember counting WBC in the blood, peripheral blood, you had also use the Newber's chamber, and you have done the same thing here, but here we use the RBC pipette for mixing CSF. So this is one of the uses of RBC pipette apart from counting RBC. For CSF count also we can draw, and this is the diluting fluid, the crystal violet for the staining, and glacial acetic acid to break down the RBCs, and distilled water to make up the dilution. So this is the way we count the total count. We count in all the 9 squares of the Newber's chamber. And in a differential count, we would like to make a smear, a stain, just like a peripheral blood smear. We can make a smear and stain it either with Giemsa or with Leishman's and look for what other types of leukocytes in the CSF. So in this case, when we receive the CSF, usually for the total leukocyte count, we prefer to not dilute the CSF. We directly draw the CSF into the pipette. But for a differential leukocyte count, we want as many cells as possible. We want to identify whether they are mostly neutrophils or mostly lymphocytes, which is what the clinician wants us to tell them. So in this case, we take a small amount of CSF and we centrifuge, and then we make smears from the sediment, we stain and we examine. Then chemical examination, this goes to biochemistry. Mainly we look for the glucose and the proteins, and usually glucose and proteins, they fall in case of bacterial meningitis. The glucose level of the CSF will be remarkably low. In tuberculosis, it will be low, but not so low. And in viral or fungal also, it will be slightly on the lower side, or mostly it might be normal. Proteins also in bacterial may be a little bit low. In tuberculosis, it may actually be a bit high. In fungal and viral, it may be on the normal side or maybe borderline low. So microbiology will basically, the smears, they will, like I told you, it has to be absolutely sterile so that they can culture, and they can culture for looking for bacteria, tuberculosis, or for mycology, that is fungus. And these smears made by microbiology, they can stain with Gram stain for bacteria, Zeal-Nielsen stain for acid-fast bacilli, and India ink for the capsule of Cryptococcus. If we are suspecting Cryptococcus, I hope you know that Cryptococcus is a fungus, and usually if you see fungus in the CSF, you have to see whether the patient is immunosuppressed, or we have to look for, do some retroviral studies and check whether the patient is HIV positive. So this is a beautiful picture of a Cryptococcus neoformans in the CSF. This is a Giemsa stain in which you can see that there is something looking like a nucleus here, and there's a space here, and it's very nice round structures. This is basically a capsule which has not taken the stain. And this is an India ink preparation, which is done in microbiology. And in India ink, it more or less confirms a Cryptococcus. You can see that the nucleus is stained, but the capsule remains unstained. That's why it looks like a halo around these nucleus. And some of these forms also are budding. They're in the process of cell division. And this is classical description of a Cryptococcus. The sizes will vary. Some are very small, some are very big, some may be dividing. But the classical feature is the unstained capsule around it, which looks like a halo. This is an India ink preparation for Cryptococcus, which is extremely important to confirm cryptococcal meningitis in a immunosuppressed patient or HIV positive patient. Immunological examination may also done with the CSF. We can look for viral inclusions by immunostains. PCR can be done to look for viral DNA and tuberculosis. ELISA can be done for tuberculosis, and VDRL for syphilis. So these are some important findings of CSF. The appearance, if it's normal, it's clear and colorless. In acute pyogenic or bacterial meningitis, it's purulent or turbid or cloudy. It basically looks thick. So in this case, I remember telling you that for CSF, in total, when we want to count the total leukocyte count, we do not dilute. But actually, it depends on how the CSF appearance is. If the CSF looks like water, then we do not dilute and we count the total count. But if the CSF looks cloudy or purulent, and it's going to be a little bit viscous, then we need to dilute and then take that into the calculation of the total leukocyte count. In acute lymphocytic meningitis, the CSF is more or less clear, or it may be slightly turbid. In tuberculosis, it may be clear, maybe slightly turbid, but when you leave it standing, then it forms a kind of a fibrin clot. That means it forms a kind of a thick turbidity, just like if you remember heat test for urine for proteins. So you fill the urine in the tube and then you heat the upper part and it coagulates. That is exactly how the CSF of tuberculous meningitis will look like if you leave it standing for some time. Okay? Then the CSF pressure normally is 60 to 150 mm water. Remember, CSF pressure is always measured as water in sense or in this mm water. Then in acute pyogenic meningitis, it will be raised. Acute lymphocytic will be raised. In tuberculosis, it will be very, very high. Cells normally 0 to 4 lymphocytes per cubic millimeter. In acute pyogenic, you will find lots and lots of neutrophils, okay, above 1,000 cells. In acute lymphocytic, you can find lymphocytes. They may be slightly higher than normal, or there may be lots and lots of lymphocytes. If there are loads of lymphocytes, then we can think of tuberculosis. Proteins normally is 15 to 45. In acute pyogenic, it is raised. In acute lymphocytic, it's raised. Tuberculosis, it's raised. Glucose, like I said here, if you look at the glucose level, 50 to 80, in acute pyogenic, it is usually very, very low. In acute lymphocytic, it may be normal, maybe slightly low, but normal. In tuberculosis also, it's low, but not as low as pyogenic. And bacteriology, of course, if it's normal, it's sterile. If it's acute pyogenic, microbiology will do a gram stain and identify what bacteria it can be. And through the culture studies, they can actually say what is the organism. Acute lymphocytic meningitis will usually be sterile. And in tuberculosis, tubercle bacilli may be shown. So, neutrophils in the CSF, you can get in bacterial meningitis, brain abscess, brain infarct. Lymphocytes in the CSF, viral meningitis, tuberculous meningitis, fungal, parasitic, all of these will contain lymphocytes. Malignant cells in the CSF, it may be any of these. And remember, practically, acute lymphocytic leukemia is what we do practically. We do the CSF in children with ALL and see whether lymphoblasts are seen in the CSF. So this is my last slide, and we have completed CSF analysis. Okay, thank you.